Welcome to the RCSI University of Medicine and Health Sciences. This is our 11th Conversations That Matter series in collaboration with the HSE. The topic this evening is COVID-19 and vulnerable groups, prison services and homeless services. I'm very pleased to welcome our panel of experts this evening. Dr. Miriam Colleran, consultant in palliative medicine from St. Bridget's Hospice and Naas General Hospital. Dr. Angie Koos, probably pronounced that wrong, sorry Angie, Medical Director, Capuchin Clinic and Safety Net Primary Care, and Dr. John Fitzsimons, Consultant Paediatrician, Temple Street Hospital here in Dublin, and Clinical Director for Quality Improvement, with Emmett Conroy, National Infection Control Manager with the Irish Prison Services. Over the past 3 weeks, our Conversations That Matter focused on leadership in healthcare, and we heard from leaders such as Paul Reid, Philip Crowley, Professor Michael West, Lorcan Birthistle and Dr. Justin Brophy. This evening, we are switching our attention to vulnerable groups, in particular prisoners and homeless people, that haven't maybe received a lot of the spotlight, but we know that there has been significant amount of collaborative and really good leadership work going on to keep these groups safe and well. Angie and Emmett will share their stories this evening, their leadership challenges and the learnings, specifically and during COVID-19 crisis. Our talk this evening will finish in about 45 minutes. Our listeners have an opportunity to put questions to our panel, and my colleague Tina Joyce will collate the questions for the Q&A session at the end of our talk this evening. I now would like to pass you over to my colleague Miriam, who will start the discussion this evening with Angie. Thank you, Miriam.
Caroline, thank you very much. It is an honour today to discuss COVID-19 and vulnerable populations with you, Angie. This embodies total person care and individualised patient-centred care. As Dr. Ira Byock, past president of the American Association for Hospice and Palliative Care, stated in his book, The Best Care Possible, A Physician's Quest to Transform Care Through the End of Life. A caring society metaphorically says to the frail or dying person, we will keep you warm and dry. Help with personal hygiene. The community reassures the person who is too frail to care for himself or herself, we will keep you clean. So given that, as Martin Luther King Jr. said, the time is always right to do what is right. Angie, you're very welcome here today, and I'm looking forward to you sharing with us about the healthcare needs of vulnerable groups in this era of COVID-19. But firstly, would you kindly explain to us what is meant by inclusion health and vulnerable groups?
Thank you, Miriam. It's a privilege to be part of this webinar series, and I'm very glad of the opportunity to share with you some of my experience of and passion for the area of healthcare that I work in. Most of the areas that I work in come under the umbrella term inclusion health, and they're all groups who have much higher morbidity and mortality than the average population. They usually have much less use or perhaps less appropriate use of healthcare services than the background population. They include people who live in homelessness, people who live with addiction issues, travellers and Roma people, and migrants, usually people who are asylum seekers or people with no recourse to public funds. Okay. Inclusion health exists really to try and reverse Tudor Hart's inverse care law, which states that access to good medical and social care varies inversely to the needs of the population it serves. So huge progress has been made in Ireland in these areas in the past 20 years. Specific services have been set up to deal with the needs of homeless people, Roma people, addiction services, and all across the country there are organisations who have come together to provide a network that addresses people's basic needs such as accommodation, food, social care, and helps them integrate with healthcare.
Okay. And you had been explaining to me before when we were chatting, Angie, about principles that guide and underpin this health.
Yeah, the real tenets of inclusion health are the first is that everybody has a right to healthcare, but that statement is only meaningful if it's healthcare that they're able to access.
Okay.
There's no point in sending somebody an appointment for a hospital clinic if they live in a direct provision centre in Carrickmacross and they have no transport and nobody to mind their autistic teenage son who can't bear travelling on a bus or sitting in a crowded waiting room.
Sure. And I think sorry, you were saying?
So another one of the tenets is that social circumstances are one of the biggest determinants of health. So if somebody's living in a ditch or can't afford decent food, that's going to drop their life expectancy.
Sure.
And one of the things that's most important to me is that for healthcare to be effective, communication has to be effective as well. People need to be able to have a conversation with their doctor or their public health nurse. And for people who don't speak English, they need access to interpreters. That's one thing that we're missing in Ireland for general practice.
Okay. That's very important. So I suppose I was wondering, what challenges did you face with COVID preparedness for these vulnerable groups?
Well, when we knew COVID was on the way, lots of organisations came together to try and anticipate the problems that our groups in particular would face. And probably the most important one we felt was that they wouldn't have the ability to practice social distancing or self-isolation. Many families in homeless accommodation, the whole family lives in one room, or single adults might be 4 or 5 to a room. And economic migrants who come from poor countries often live in very overcrowded private rented accommodation. We've all seen television exposés of landlords renting 3-bedroom houses to 20 people who probably work in a meat factory then. So lots of risk factors there.
Okay. And so what you're saying, Angela, really reminds me of what Dr. Mike Ryan, the executive director of WHO Health Emergencies Program, when he said, "None of us is safe until all of us are safe." Would you like to tease that out a little bit more for us?
Yes, that's so relevant when there's an infectious disease spreading through the population. The easiest work will solve the problem for the smallest amount of work will solve the problem for 80% of the population. But if you don't get that other 20%, then the infectious disease is going to stay there and keep spreading.
Okay, so how did you do that? How did you help that extra population?
Well, the interagency working and the interagency response and the cooperative working was amazing. The first thing was that accommodation providers quickly secured lots more accommodation. They got hotels and holiday apartments, so they were able to decongregate people and spread them out, so that they reduced occupancy in hostels by something like 30 to 50%. They also set up special self-isolation and cocooning accommodation, so that homeless people who had bad COPD or something could be moved to a little apartment where they could cocoon. And then self-isolation apartment where people could move when they developed symptoms or if they tested positive for COVID.
Okay.
So much was done that it would probably be confusing if I just gave a list of things, but I wondered if I have a few scenarios that I could describe to you.
Yes, please, that'd be wonderful.
And highlight things.
Yes.
So one Friday night, a staff member heard Joe coughing. Now, Joe is a man who lives in a hostel in town, shares a bedroom with 3 other men, and attends the National Drug Treatment Centre, where he goes to collect his methadone every morning. On the way home, he usually buys 10 to 20 diazepam tablets, which he takes throughout the day. He has asthma and is prescribed inhalers for that, but often runs out. So the staff member asks, maintaining a safe 2-meter distance, gives Joe a mask and directs him to the self-isolation room that has been set up where he can spend the night. Then they ring the safety net free phone number that was set up for that purpose and explain the situation. So a GP will ring Joe back then and talk through what's happening with him. Both of them agree that Joe's not too bad, but he does need a test for COVID. The next morning, the COVID team arrives at the hostel and does the test. Then a specially adapted taxi arrives, picks Joe up and brings him to the self-isolation accommodation that has 24-hour support. A nurse there contacts the National Drug Treatment Centre and talks through the problems. They deliver a week's supply of methadone, and a doctor speaks to Joe on the phone. both of them
Okay.
agree that Joe is never going to stay in self-isolation for 14 days if he's going to start getting benzo withdrawal symptoms.
Oh, yes.
So they deliver a supply of diazepam as well to keep
Okay.
him going.
Okay. Okay.
2 days later, Joe gets his cough and his wheeze gets worse. So the mobile assessment and treatment team come out to visit him.
Okay.
They prescribe him steroids and antibiotics. That's all he needs. And the next day, his COVID result comes back and it's negative. So that's
Okay.
good.
Yes.
But he stays on in the self-isolation for another week until he's better.
Okay.
And then at the end of that, he's happy that he's better, but he's sorry to leave.
Okay.
Because for the first time in years, he's been able to wash his own clothes in a washing
Oh,
machine.
yes.
And he's been sitting on a balcony chatting to other people across the way while
Yes.
he's eating the sausages and eggs that he fried for himself.
Oh, lovely.
So there are things like cooking for yourself and washing your own clothes, and that
Sure.
homeless people can't do that. And the sense of independence and dignity it gives them is amazing.
Yes. 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 And so
I had another scenario.
you
Oh,
were so individualized and patient focused and compassionate care.
yes.
It's so important. Compassionate care. Would you like to give us another scenario?
So there's the other kind of areas that are involved are people who don't
Yeah.
speak English.
Okay.
So a woman rang up the National Roma helpline that again
Okay.
was set up for this
Yes.
because we knew
Yes.
that making that first point of contact would be difficult for people who didn't speak English.
Sure.
So she's living with her husband and children in a 2-room apartment in the inner city, with both sets of grandparents as well, and they're sharing bathroom and kitchen facilities with 2 other families.
Okay.
Dad has developed a cough and a fever. He normally works in a waste recycling plant, but he doesn't have a PPS number, so they're not entitled to any benefits.
Okay.
The helpline offered to get them all moved to self-isolation, any or all of them moved to self-isolation accommodation, but they refused because they thought that if they did that, they'd lose their 2-room flat and then they'd be homeless afterwards. They'd be living on the street. So then he offered to send the testing team out to do the swab. That wouldn't be okay because then the neighbours would know they had COVID and they'd be attacked and evicted.
Oh gosh.
So then one of our GPs rang him with an interpreter and he agreed to come into the community assessment hub that was set up beside the matter if a taxi collected him.
Yes.
So that happened. We did the test. We got a rapid result. We had the facilities to do that because we knew people wouldn't hang around waiting for results.
Okay.
So we got a result within an hour and it was positive, but he still wanted to go home.
Okay.
And we knew by then that Roma people seemed to be much more susceptible to the severe forms of COVID.
Oh.
So we were able to give him a thermometer and a pulse oximeter and show him how to use both of them.
Sure.
So he went home with that and with masks and hand sanitizer and soap. And every day for the next 4 days, a nurse and a GP phoned him on a WhatsApp call.
Okay.
He wasn't good with numbers, so they were able to do the video call and look at the pulse oximeter as he was using it so they could see how he was doing.
Yes.
And then on day 4, when they rang, he was breathless and his SATs were down to 93%.
Okay.
So he needed to go to hospital.
Mm-hmm.
But there was no way he was going to hospital.
Oh, okay.
Because he had heard that Roma people in Dublin had died of COVID. And somebody told him that if you're Roma and you go to hospital, they're going to give you an injection and die.
Oh.
So we, with his consent, we rang the Roma helpline because that's run by a member of the Roma community.
Okay.
And he rang the patient back and managed to persuade him that the matter's okay. Nobody's going to give you an injection that will kill you in the matter.
Okay.
And he went off there.
Okay.
In the meantime, during these days, a volunteer bicycle courier had been delivering cooked meals, nappies, and baby milk from the Capuchin Centre to the family. Mendicity had been sending food parcels. Granny had run out of her diabetes medication, so we had emailed a prescription to the local pharmacist and they had delivered it to the family. So those services all kept them going and kept them able to remain in self-isolation until their 14 days were up. And then Dad got better and came home. So it was a good ending.
Yes, yes. Yeah. And incredibly comprehensive and integrated healthcare.
Yes.
I mean, it was very integrated.
It was, but that's the experience. That's what's happened over the last 10 or 20 years in Ireland. Is different groups have been working with all of these marginalised groups of people,
Yes.
and so there's always somebody that knows what they need. Like
Okay.
I've worked with the Roma community for quite a long time,
Yes.
but when we got an actual member of the Roma community on the
Yes.
helpline, that
Sure.
made a huge difference.
Of course.
So sometimes people would trust them, he would trust me, and
Sure.
then we were able to link it all together.
Yes, yes, yes. Oh, that's gosh, I wish we had 2 hours instead of instead of the time we had. That is that's been incredibly comprehensive and really, really helpful to hear, Angie. We need to pass over to John now, but we'll be able to chat more in the Q&A.
Thank you.
Thank you very much.
No, thank you, Miriam, and thank you, Angie. That is really that's really inspiring there. Thank you very much. And Emmett, you're very welcome. Thank you for joining us this evening.
Thank you very much for giving me the opportunity to speak on behalf of the Irish Prison Service.
Yeah, fantastic. It's great to have you. And I think your story, I think, is equally, inspiring. And I think I was just struck listening to Angie there, really, talking about how well they know their population and what you have to do to meet those needs. But I think in your case, you have a very particular population as well. And you might just tell us a little bit about what makes that population different and your role, I think, working with those with that population.
Yes, well, to capture what's going on inside the prisons today and how successful we have been at keeping COVID out is still today we have no positive cases of COVID inside any of our 12 prisons across the country, which is a remarkable feat. And it's down to, I have to go back as far as 2017 where it all began, and the introduction of the infection control program. I was promoted to infection control manager. I was asked to look at the prisons and how we were going to introduce an infection control program. You might remember back as far as 2011, we had a TB outbreak, and unfortunately 200 prisoners and staff got TB. Yeah. Many of the prisoners brought it home, unfortunately. Staff brought it home, infected their children. So there was lots of lessons we learned from that. So for me, I looked at our prison environment and there was two key factors. It was our prisoners and our staff. And prior to TB, no one had received any infection control education. So I looked at a model that I thought would work. And after working in prisons for many years, prisoners listen to prisoners. And prisoners don't listen to me. So we developed a peer-to-peer healthcare module in infection control. We basically picked key prisoners. What I mean by key prisoners, when you walk onto a landing, we describe their landings as the community, their cells or their homes, because this is where these people live. And we looked at each in the environment and we were able to identify key prisoners who other prisoners looked up to. We asked them, would you be interested in becoming volunteers through a Red Cross program? But we would bring them into the classroom, we would teach them about infection control, and then they would go on to the respective landings and carry out project work. And to date, we have 7% to 10% of the population trained up as trainers. These wonderful, wonderful prisoners, they're volunteers, they're officially identified by the Red Cross as volunteers, and they do fantastic work. Right from the get-go, they bought into it, they looked at their environment, because they got education on the environment and the risks associated with prison, because many areas are shared, you have your gyms, you have your schools. There's very little hand washing, there's very little awareness around cleaning, all of which was incorporated into their educational module. And it was a case of prisoners teaching prisoners. And I think fantastic.
I think listening to Angie talking about inclusion health, I mean that to me is as inclusive as you can get. And I mean, how do you convince people, because it's not, it's not maybe the first way you would think of doing things. How do you convince other people that this is the way we're going to tackle this? This is a big, I suppose, threat and fear for everybody, and we're going to get the prisoners to teach prisoners.
Yeah, well, thankfully, my bosses, that's my Director General and my Director, believed in me. I looked at this, I've worked with prisoners, I've been involved working with Fiona Lyons in previous HIV studies and work done in prisons. So prisoners respect people who respect them. And I think that's key. Prisoners are people, you know, the same as myself, yourself, any of us. I mean, I know lots of prisoners that, to be honest, we're always going to end up in prison. I listen to the stories that had, you know, they try not to, but they end up there. To get the trust, you've got to respect them. And if you show someone respect, you will get that back. And that's the key. And we've done the same for officers. We provided education and infection control education for officers as well. And I used the same approach. I trained up prison officers as train the trainers. So I had prison officers training prison officers. And the prison officers trusted the message the same way the prisoners did, because the prisoners lived in the environment and the officers were talking about an environment that they worked in. So I had immediate buy-in. And we were very lucky. We've done a huge projects around cleaning. All our prisoners now are trained up to a clean class program. And clean class program is a standard which cleaning is done in public areas. We had a look at hand hygiene, and we fitted out every prison last year with a hand sanitizer that we got developed in England that was alcohol free, so the prisoners could drink it and you might get an upset tummy. It was antivirucidal and antibacterial, and it killed COVID. We got a product into every cell, a Sandy 4-in-1 that prisoners used, and it was a phenomenal response. I mean, what we found when we're teaching the prisoners then were teaching their families on visits. Really? So not only were we educated inside the walls, our message was going outside the walls, direct to the families.
And that must be empowering for prisoners as well. I mean, and I suppose creates a sense of trust. I mean, back to you and to your fellow staff.
Yes. Well, it was one thing we've seen was prior to the introduction of the infection control models, because of the route we went to roll it out, prisoners started to trust staff, and staff started to trust prisoners. We've seen better communication. We've seen more projects for staff and prisoners working hand in hand. I mean, if you walk down a landing, you have a prisoner doing a hand washing technique with the glove box. I'd stand back, you'd see staff getting involved, washing their hands and learning how to wash their hands. Yeah. And all this work was done prior to COVID. So when we knew COVID was coming, we started speaking to the prisoners. We designed a COVID-specific educational piece, which included donning and doffing, because we knew from looking at what was happening in China and other countries that it may be a case for not only staff who were in PPE, but the prisoners will have to wear PPE too. So we trained up 188 staff as donning and doffing trainers. And we also trained up in every prison 10 prisoners who were donning and doffing trainers. So we rolled out huge donning and doffing across the estate, through all staff, through all prisoners, and then we done a huge awareness around COVID. So when it came to looking at our risk factors, the risk factors were the staff coming in from the community and the visitors. So we knew our exposure risks were from staff and prisoners. And we spoke to the prisoners, we communicated, and we said, look, guys, because unfortunately at that stage we had many deaths in prisons in other parts of the world, of both staff and prisoners. And staff were hearing this, and so were prisoners. Now prisoners were getting worried. So the prisoners actually approached us and said, look, we need to stop visits, which we couldn't believe, because they knew it was a risk factor for those, for the prison.
And that was a concern that was coming from the prisoners, you know.
Yes.
Yes.
And we had many prisoners who declined visits. Also staff, then we looked at staff coming in. We introduced staff screening, and the prisoners, when the prisoners heard we were screening our staff for temperatures and questions, they were relieved, because the prisoners were afraid of the staff, because they knew that they were the risk because they're bringing it in. And together it has worked really, really, really well. There was a huge awareness campaign. If you felt unwell, put up your hand. So every day, if a prisoner felt unwell or had a runny nose or a cough, he stayed behind his cell, and when the officer came to the door, he'd say, I feel unwell. And they were immediately referred to clinicians and assessed. We broke it down. Then we decided from the 1st of April to the 20th of May, we had 699 committals. all of whom we put into quarantine for 14 days. And this was agreed, and it was Red Cross volunteers explaining to the new commitments the process.
Yeah.
So again, it was prisoners explaining to prisoners. Prisoners helped us write the information leaflets. We worked with, it's very important and a key message here, to know your audience, because we worked with literacy teachers to make sure what we were producing was understandable. Because we do have a lot of literacy issues among the prison population, and also we have this morning, I believe, 72 different foreign nationals, many of whom don't speak English.
Yeah.
So it's important to we put together lots of pictograms to help them.
And I presume it's not easy to go into quarantine unless you really understand the reasons for why you need to do that.
Yes, because that's where we got the buy-in, because the prisoners understood, if I come out of quarantine, I can go back in the general population. And they also knew they were safe. So it was reassuring for every prisoner as well. So it worked really well. And then on top of that, we working with the National Quality Improvement Team, we co-produced a model of contact tracing that is anyone who is symptomatic and meeting the criteria for testing, we contact traced immediately. And we put them into isolation for both staff and prisoners. And we also went out and looked at their contacts and put them in isolation or would not allow them to work, put them into quarantine. As a result, if and when a staff member did become positive, there was no risk of contamination exposure to any prisoner member of staff. So it has worked. Like in total, we have over 40 staff who got community-acquired COVID, but because of the controls in place by the staff and prisoners, there was no exposure within inside walls. The WHO has just accepted a paper of this and are promoting it as best practice, which is fantastic news. We've had the Norwegian Red Cross, Canadian Red Cross, the South Americans are ringing me today. They want to know about it. They want to use it. The Northern Ireland Prison Service are using the model, and now England is using the model.
So that's a fantastic achievement, you know, for the Irish Prison Service and for you and for the National Quality Improvement Team and all that collaboration.
And the prison population.
Yes, of course.
It's because
their success.
And because we're inclusive, and we were with the prisoners every step of the way. It was because we had built up a working relationship with public health, HSE, and we always have been inclusive, and that model works.
And what do you think the legacy of this will be, Emmett? I mean, hopefully, you know, COVID will pass, you know, but yes. I imagine this is potentially kind of a new way of working as well, and I would imagine it will leave an imprint.
It's a huge imprint for myself, prisoners, staff, and my senior management. Without a shadow of a doubt, the key here is a collaborative approach. I have to say the National Quality Improvement Team was phenomenal. And what I have learned is it's very important for HSE and people I've worked with, when thankfully the people I've worked with and the success is based on because they listened and understood our environment. Our environment is very unique. It is very, very unique. And when policies and procedures are over outside for community, they can't necessarily be operationalized within inside our walls. So thankfully, all the specialists I've worked with accepted that and appreciated that. And I've had a very good collaborative approach before with Professor Martin Cormacan when we co-wrote the Prison Specific Guidelines for CPEs. But it took me to take Martin into the prison to show him the environment for him to say, you are that unique. And I think that's the approach. So any work I'm going to do from here on in, you're coming into the prison with me first. That's the way it's going to be.
Oh, look, it's really fantastic, and congratulations to you and to everybody, including, you know, all the prisoners who've been part of this. And I think the fact that no prisoner in Ireland has tested positive, I think, is a tremendous testament. And we have seen other places in the world where, you know, it's been grim, and I must say, well done, and thank you for sharing that story. I'm going to hand over to Tina to see, because I'm sure there'll be lots of questions for yourself and Angie from our audience. Thank you.
Thank you very much, John, and thank you very much, Emmett and Angie. There's lots of comments and questions coming in, congratulating both of you on the work that you've done and that you are doing, and just the leadership. If ever anything encapsulated collaborative leadership, respect, trust, all of those characteristics and values, I think we've heard real examples of them here tonight. So I suppose the first question for yourself, Angie, that has come in, as we kind of come out of this acute phase of COVID, what would you like to see remain? What would you like to see continue?
With the collaborative working, that's the thing, and the sort of recognition that the way to get things done is to let people do it. So every problem that arose, somebody had a solution to it, and somebody put their hand up and said, "I'll sort that out," and people just needed to be allowed to do it. Lots of sort of bureaucracy was suspended. So there's always been quite a long waiting list for some people to get onto opioid substitution treatment or methadone. That disappeared overnight because people just said, okay, fire ahead. So that way of letting people get on with what needs to be done is really, really important.
Okay, thank you for that. Emmett, over to yourself. When you talked about training up and about the importance of peer-to-peer education and learning, how did you identify prisoners? Did you just ask for volunteers? How did you identify people to come forward for that?
Yeah, we literally ran an awareness campaign and we asked prisoners who want to get involved in peer-to-peer education to come forward. We spoke to them, we literally interviewed them, and from that then we cut our core teams. Because what I did find, if you force someone into peer-to-peer education who doesn't have an interest to do it, it won't work. That I have learned that.
Okay. And back to yourself, Emmett, what do you think are the critical success factors for having a situation where no prisoner got COVID-19? And was there any risk, or from an ethical point of view, of prisoners' rights being violated by the fact that they weren't able to mix more freely?
Yes, there's a two-part question. The first part is the collaborative approach. The collaborative approach of IPS to the HSE, the HPSC, to the WHO, and also the IPS with the prisoners, with the Red Cross volunteers. It has been key. It's been pivotal. The prisoners knew what was coming before any control was put in place. And what they knew the importance of putting the control in place. No prisoner, okay, the one or two prisoners were upset. They had a right not to be isolated, but there was no human right infringement. It was looked at and everyone was happy. It was the greater good of the prison population. The difference of someone being infectious inside that closed environment is it would just sweep through the prison overnight. You could lose a prison. So on that basis, prisoners understood the reason behind the controls.
Okay, thank you, Emmett. Angie, back over to yourself, just in how you described that, the whole piece around interagency working. Do you think there's a greater understanding now of vulnerable groups? Do you think that there's a greater, there's more compassion, there's more understanding? Is that your experience?
Yes, definitely, and about the differences between all the different vulnerable groups. So the needs of one vulnerable group might be completely different to the needs of another. People who don't speak English need an interpreter, and staff and healthcare workers and agencies who don't have experience of that don't realise how important it is until they're put in that position and they see how well it works. So the fact that we all came together on teleconferences and in self-isolation units, and we all saw how the other people were doing it, and it was like a light went on. So it was a revelation to a lot of people. And it gave great credibility to all of the people, that the workers that would be considered less skilled or less valuable or less highly paid, because they were the key to all of us, really. They were the people that knew most about how the clients and the vulnerable people worked and what would persuade them in. Somebody had a great story about a Mars bar crispy cake that got somebody with HIV into hospital, and so it's that personal on the ground familiarity that really helps. And what COVID has done has brought groups together so that we're all recognizing what other people are doing and what works.
Okay, thank you for that. Thank you for that, Angie. In terms of how this this has been managed. Do you think that this will change how you do your work in other areas, not just in COVID-19? Is this setting some kind of a precedence for how work might continue and other projects might happen in the prison services? Might go to yourself first, Emmett. Are there lessons here that are transferable and generalizable across the prison services?
Yes, there's huge lessons we learned here. The importance of everyone. I'm going to keep going back to the collaborative approach, and everyone has a voice. That is the key. And like I said, Angie, I found the same. You'd have a room full of people, everyone was listening, everyone had an opinion, and everyone worked really closely together. I mean, when I started this in 2017, doors, I found it difficult to open some doors in regards to get people to look at my SOPs, my on TV, what we should be doing, what we shouldn't be doing. And now it's completely turned on its head. People are coming in to helping, to want to work with us. And that's something that I've said to all the people I work with. This is the start of something fantastic that we must continue to do. And it's definitely something that my bosses have given full go ahead to continue working with everyone. It's going to make it safer, I think, more secure and more open environment in certain respects. When you think of a prison, you think of closed gate. And actually, this is new for us. We're opening our doors, which is fantastic.
Okay. And there's a comment in from Fanula, and it's to yourself, Angie, and she's talking about how the story that you have told there highlights just the importance of people having a home and somewhere where they can look after themselves and manage for themselves as well. And she really just wants to congratulate you on all of the work that has been done by you and the other stakeholders on behalf of the people that you work with. So is that something, again, that you think is really important? And
it's so important, and I hope, I mean, it will probably come down to money, but I hope that one thing that comes out of this will be the recognition that humane accommodation is so important. It's watching a mother being able to cook for, I know that's very gendered, but watching a Roma mother being able to cook a meal for her children for the first time in 2 years it's just, and the difference it makes to all of them, it's so central to their culture. So on one level you could say, well, you know, they're being accommodated in a lovely room and all the food is provided. They don't want their food provided. They want to be able to do what they do as a family and have the dignity. They want to be able to make decisions for themselves about what food they eat and what food they don't eat and what time they go to bed and what time the kids get up. And that's what we all do in our own families at home. And for people to be integrated into society, they need to be able to live those normal lives that the rest of us do.
Yeah, okay. And we still have lots of questions and comments coming in. And I suppose for yourself, Emmett, there's a couple of questions coming there around mental health issues in prisons, and to what extent mental health features in the preparations around COVID-19, as well as the physical isolation. What attention do you need to pay to mental health issues?
Yes, mental health was really looked at, and people's, like, I mean, take away anyone's freedom, and you know, it's quite difficult. But to be in quarantine for 14 days or in isolation or cocooning, because we have a number of prisoners cocooning because they're elderly. We designed basically online calling, video calling, and it was novel. And the reason it was novel because not only did the prisoners see their families, but they're able to see their homes, their dogs, their back gardens, and we see huge positive. Like you see prisoners absolutely beaming after the calls, and that helped a lot. Also, we had psychology on tap on phone, so they get a phone into a cell and I could speak to the psychologist anytime they wanted. And also, we have a listener scheme where prisoners are trained as listeners, and if and when they need to speak to someone, that was accommodated. Obviously, social distancing, and that helped a lot. But I think this is new and novel. These new video calls. Yes, that definitely did help.
Okay. Well, as we said earlier on, we have lots of comments and questions, and I think Miriam said that we'd need 2 hours. I think we probably would need longer than 2 hours. I think we've just heard leadership encapsulated in both of those stories and experiences. And normally at this point, I want to thank Angie and Emmett, and we normally hand back now to Caroline. But just before we do that, I just want to highlight a publication that John Fitzsimons, who is on our panelist, has done. So John, we see this paper here from ISQA, and it's around quality and safety, and it's freely available.
Well done, John.
I think it's a really important publication. So John, would you like to tell us a little bit about the publication and how it came about, and what you know, how we can access it?
Yeah, thanks, Tina. Thank you to ISQA, I think, and I must give a shout out to ISQA, the International Society for Quality in Healthcare, who I think really have been outstanding throughout COVID, I think, with the resources they have provided, both, I think, video and then printed resource. This was really a paper just looking at the use and the application of quality improvement thinking and principles in COVID. And I think you know, you've had a lovely kind of, I think, example from Emmett and Angie there about you know, the importance of knowing what it is you need to do by knowing the people you're caring for and what their true needs are. But I think alongside that, quality improvement methods, thinking and skills can be really helpful, because there's lots of assumptions we make along the way, and there's lots of times when we kind of maybe we want to kind of leap in and do things, but actually, you know, we need to sometimes stop and design and think a little bit. And I'm sure this is what the quality improvement team brought to Emmett's work, you know, is a set of skills that run parallel to the people who know what people need, you know. And so it's critical, you know, I think to be aware of this. I think it's something that everybody in healthcare should know about. It's not rocket science, you know. A lot of it is really simple ways of thinking. And I think between, you know, papers like this, but also there's lots of stuff. The National Quality Improvement Team's website has lots and lots of information. I think I point to that website in the paper as well. So lots of good Irish resources out there, as well as international resources. But thanks for highlighting it.
Okay, back to yourself, Caroline.
That's great. Thank you, Tina. Thank you, Tina, and thank you, panel. It has been a really interesting, rich conversation, and I will absolutely agree with Tina and with Miriam. I'd say we could sit here all evening if we were allowed. Some just salient points that I picked out. I'm going to start with Angie, if you don't mind. It's all about inclusion health, and that everyone has the right to healthcare. The whole thing around social circumstances, and that is a big influencing factor in health, and we need to look at that and address the underbelly of that. Also, Emmett spoke a little bit about this too. It came right through both conversations, that knowing the people you are looking after and caring for is really important to help adjust to their needs. So it's really about meeting individuals where they are at. And Angie talked a lot about the inclusiveness of health and the comprehensiveness, and Emmett said the same, and how that during COVID, how the bureaucracies, as Michael West said, were softened in a way, and that people just got out of the way and allowed the people who have the experience and the expertise to do what they needed to do and just get on with it. And I thought a beautiful sentiment about the humane approach in relation to the Roma community, and the fact that, you know, these are just people trying to live their lives and being given the dignity of what we take for granted in terms of, apart from our homes, but just making a meal, and how that they just want to live normal lives. So they were some of the key things I took from Angie, and thank you so very much. From Emmett, it was a great visit down way back to 2011, and I never realized that over 200 staff and prisoners got sick with TB and brought that home. And the beauty of that was you sort of had your own mini little pandemic, if you like, before COVID hit. And then you came in and introduced a system-wide infection control program, and knew that the best way to transfer that learning was through peer-to-peer, which was your prisoners listen to prisoners. You know, I mean, this is how we teach, and it's amazing that now you have 7 to 10% of the population trained. So you were sort of ahead of the posse, if you like, before we were hit with COVID. And some of the interesting things you talked about, and you spoke about the importance of collaboration, but how that the prisoners themselves identified risk factors as prisoners, and also the staff screening made prisoners quite scared of staff bringing COVID into their organization, if you like, their world, and how that you developed a huge awareness campaign. And I think it's fantastic that you have accepted your paper and that it's getting excellent recognition from around the globe, and fair play. And I think the shout out to the HSE and the support that they provided, and we saw that when we had the HSE leaders here with us speak about the fantastic work that's been happening in the HSE, and sometimes people don't shout that out loud enough, in collaboration with quality improvement and indeed all of the other groups that you mentioned, and that the take home was collaborative. It's all around collaborative and inclusion. So whatever label you put on it, we all have a part to play and we're all people. So thank you so much. And there's so much more. I've loads of notes here, but I'm noticing the time, so I have to stop talking. And I want to thank you again for taking of the time this evening, and all of the time that you've taken in the background to talk to John and to talk to Miriam. And just to say that we have a COVID hub, and we have a series of podcasts available on our hub, and also tonight's podcast will be recorded and available. And we'd like to invite our listeners back to next week's, the 18th of June conversation. And we're going to have COVID-19 telling the story. And we have the privilege of inviting Susan Mitchell, who's health editor of the Sunday Business Post, and Dr. Mures Houston, award-winning medical journalist, talking about health analytics. So any comments or suggestions that you may have for future conversations that matter, could you please email them to rcsileadership@rcsi.com. So a big thank you again to our panel. We really are delighted, a very rich conversation. To our listeners who took the time out to listen in, and again back to our support team in the backgrounds, all of the team members whose relentless work behind the scenes wouldn't make this happen. So this magic happens because of lots of people's involvement. So thank you, good night and good evening.
Thank you. Bye.
Thank you.
Thank you.
Bye. Thank you.